Thank you, everyone. Thank you, Iman, and the Scientific Committee for the invitation. It's an honor and a pleasure to be here, and I'm delighted to share with you our experience related to how to handle patients with a severely poor ovarian response. And we're talking about patients who are not interested in proceeding with ovum donation. And we see these patients every once in a while in our practice, especially, I understand, for example, in Egypt, where ovum donation is not permitted. So these are patients with very difficult clinical profiles. And my talk is going to be related to how to handle these patients during stimulation. So we all know that every egg counts, and this is a recent publication from last year in which the team of Dr. Valerie Baker participated in this analysis, and we know that there's a correct correlation between the number of oocytes retrieved and the probability of achieving a live birth. So this is not something new, but it's nice to see that there's recent clear evidence, which we have learned about since several years back. So it sounds easy, but how can we really obtain, how can we handle these patients? How can we maximize the number of eggs retrieved in these patients with such difficult clinical limitations? So the most common problems encountered with these patients have to do with the synchronization of follicles, premature luteinization or premature ovulation. Patients usually have poor embryo quality, a low oocyte yield, and low oocyte maturation rates. So I'm going to center my talk in how to avoid premature luteinization, given that these patients are candidates to undergo a fresh embryo transfer, and we need to avoid premature luteinization in these patients. So what is premature luteinization? This has been reported in the literature during over 30 years. Traditionally defined as a rise in progesterone above a certain cutoff occurring before the criteria of HCG administration are met. It has to include concomitantly an elevation in LH levels. So this is very important because many publications refer to premature luteinization only by the elevation of progesterone, and we have to take into account that LH also must be elevated. So given that there's discrepancy in terms of the definition, this is why we see a very wide range in terms of the prevalence. It goes from 12.3 to 46.7 patients with premature luteinization undergoing fresh IVF cycles. So there have been definitions in which cutoff values of LH have been reported above 10, above 12.4, along with progesterone levels reported above 1 or above 2 nanograms. The most common protocol used for these patients is the antagonist protocol, and we know that the antagonist protocol can fail in up to 8% of patients with normal ovarian reserve. However, the most risk is encountered in patients with advanced age, low ovarian reserve, and poor response to gonadotropins, and we encounter incidences as high as 35% of patients with premature luteinization. And again, this is just to point out that there are many publications in which premature luteinization is referred to only elevations in progesterone levels and not necessarily LH levels. So why is it important to avoid premature luteinization? We know that with patients undergoing a fresh embryo transfer, the early rise in progesterone will induce an asynchronization with the embryo and the endometrium. But what about in frozen embryo transfers? Well, there are recent reports that have also encountered that a premature LH rise suppresses the proliferation of granulosa cells. It induces oocytes to be more excessively fragmented, and we also see a higher degree of asymmetrical cleavage in these oocytes. So embryo potential may be compromised with a premature elevation in LH. So the dose that we typically use is 250 micrograms of an GnRH antagonist. And this dose was determined based on this study reported a few years ago. It was a multi-center, double-blind, randomized dose-finding study to assess the efficacy of gonadotropin-releasing hormone antagonist, ganirelix, to prevent premature luteinization hormone surges in women undergoing ovarian stimulation with FSH. So a total of 330 patients were included. They were stimulated with 150 units of recombinant FSH, and different doses of the GnRH antagonist were administered. 0.625 milligrams in one group, 125 micrograms in another group, 250 micrograms in the third group, 500 micrograms in the fourth, and then 1 and 2 milligrams in the subsequent groups. And what they saw is that patients receiving a lower dose of the antagonist were associated to a greater rise in LH levels. As you can see in the first and second group, 5 patients had a premature luteinization or premature rise in LH, and in the second group, 6 patients. In the 250 microgram group, there was only 1 patient, and with doses greater than 250 micrograms, we can see that there was no premature luteinization encountered in these patients. So why not give a higher dose? Well, in this study, they found that patients receiving a higher dose of the GnRH antagonist were patients with lower implantation rates. So you can see how the implantation rates decreased significantly when a dose of GnRH antagonist above 500 micrograms was used. And this is another very nice study published a few years ago in which 8 normal cycling women were included. Patients received estradiol patches in the first cycle, and then in the second cycle, aside from the estradiol patches, they receive a daily dose of GnRH antagonist. And what they found was that the LH level in patients receiving the GnRH antagonist still rose despite the reception of this medication. So the GnRH antagonist ganirelix at the dose currently used in IVF programs wasn't able to block the positive feedback effect of exogenous estrogen in normal women. This was, again, patients who were receiving estradiol patches, and with patients that undergo controlled ovarian hyperstimulation. So there's a description of this factor, the gonadotropin surge attenuating factor, which is produced with follicles that are being stimulated, which also plays a role in inhibiting the LH surge. So perhaps that GnRH antagonist is not necessarily as efficient as we think it is. This is a publication as well by Dr. Gressinger a few years ago, many years ago, 2006, but it was a very nice prospective observational study in which 5 women undergoing ovarian stimulation and a GnRH antagonist multiple dose protocol were assessed. The LH levels were measured every 15 minutes for 32 hours. The LH levels were measured 8 hours before the first GnRH antagonist dose, and from there on every 15 minutes until 24 hours later. And what they saw was that the antagonist was able to suppress the endogenous LH of these patients. However, you can see that there was a steady rise in those LH levels. And right before the second dose, LH levels were back to basal levels. So what this means is that perhaps that single dose in these patients with these high risk factors is not enough. These are different strategies used to avoid premature luteinization. For example, starting the GnRH antagonist with smaller follicles, 12 millimeter follicles, early trigger, which is something Dr. Lawrence will talk about, but there are many publications now that recommend triggering these patients with smaller follicles is recommended to avoid premature luteinization. Progesterone priming is another great option to avoid this phenomenon. However, we have to take into account that these patients that will undergo fresh embryo transfer cannot undergo fresh embryo transfer with this protocol. So what about using a GnRH antagonist every 12 hours? So when we use a GnRH antagonist, we are faced with, it's important to evaluate what the levels of LH, of estradiol and progesterone will be like after the antagonist, because we know, after the trigger shots. So when we trigger patients, we want to make sure that the LH rises. We want to make sure that the estradiol levels continue rising, and progesterone levels also must rise. So who measures levels post-trigger? We do in our practice normally, as we have found that there's a direct correlation between progesterone levels and the rate or the number of mature oocytes. So this was encountered in this very nice publication in which there's a correlation between the number of mature oocytes and the levels of progesterone, regardless of whether patients were triggered with HCG or a GnRH agonist or even kisspeptin. This is a study that we presented a few years ago in ASRM, and we encountered this precise phenomenon. We included 16,000 cycles, and we measured progesterone levels 12 hours after the trigger shots. And we noticed that patients who had a normal rise, considered normal when it was above 5 nanograms per ml, These patients, although normal fertilization rates were identified regardless of the level of progesterone, we did find greater clinical pregnancy rates and live birth rates in patients with greater progesterone levels after the trigger shot. So even after adjusting for age, FSH, AMH, BMI, and total gonadotropin dose, we encountered this correlation. So what happens if we use a double dose of antagonists? Would we be suppressing this production of progesterone? So we sought out to evaluate this in patients, and we presented this at ESHRA a few years ago. We included 20 patients with diminished brain reserve and who had a history of premature ovulation. We did not find that the levels post-trigger of progesterone were affected by the use of double tetratype. We further expanded this analysis to 40 patients, either with premature ovulation or premature luteinization. And again, we have not encountered any negative effect with the levels of progesterone after the trigger shot. So we also encountered a total of 72% of the eggs that were retrieved in these 40 patients were metaphase 2 oocytes. So to finalize my talk, I just want to point out that there are other different strategies that we employ to improve oocyte yield. I want to center the remaining 2 minutes in follicular flushing. We know that follicular flushing has been looked into during so many years now. There are many publications. This meta-analysis from George Gressinger, where there's there's no clear evidence of the benefit of performing follicular flushing in these patients. There's an increase in procedure time when this procedure is performed. And this is a recent update to this same systematic review and meta-analysis. It was published last year. And a total of 6 randomized controlled trials were included. And basically the same findings were encountered. Of course, larger pragmatic trials were warranted to clarify the real effect of flushing on oocyte numbers in patients who are poor responders. And again, there's so many publications that do not favor follicular flushing, but there are more recent publications that actually confirm that there may be a role in certain patients. And we have to take into account that one of the phenomena also encountered with patients with severely diminished brain reserve is ovarian fibrosis. So these patients have really hard ovaries, and this is one of the factors involved as well in the lack of response to gonadotropins. And there have been publications that correlate that the fibrosis is also associated to a decrease in ovulatory mechanisms. So these patients can have more difficulty ovulating. And if we translate this into what happens when we aspirate each follicle, perhaps the follicular wall is hard. We're not able to retrieve that egg from the follicular wall. So there's current evidence that softening tissue in aging ovaries may help fight infertility, and these are just some of the supplements that may play a role in this process. So perhaps if we identify patients who may benefit from follicular flushing, if there are any biomarkers, and then there's this question, you have more eggs, but what about the maturity of these eggs? Maybe you're just obtaining immature eggs, and what happens with the blastulation rates? So we sought out, we published this study a few years ago, in which we randomized 2 groups of patients with low progesterone levels, below 5 nanograms the day post-trigger. And in group 1, we allocated patients to undergo follicular flushing. In group 2, patients underwent a direct aspiration. And these were patients demographically similar among them. What we noticed is that we encountered a greater number of oocytes retrieved in patients undergoing follicular flushing, 4.4 versus 2.6, and the retrieval rate, calculated oocyte retrieve per follicle, was also greater in these patients. Maturity rate was the same, fertilization rate, and so was blastulation rate. Just as a note, the majority of these eggs were retrieved in the first flush. So to conclude, patients with severely diminished brain reserve are at an increased risk of premature luteinization. We do this in our practice. We measure estradiol, progesterone, and LH, and based on this, we start the antagonist with follicles between even 10 to 12 millimeters in size with these patients. We start the antagonist BID with 14 millimeter follicles in size. And just as a note, we always measure progesterone, and perhaps after the trigger, and perhaps this may be a marker that can help us distinguish which patient to undergo follicular flushing and which not. With that, I conclude. Thank you so much for your attention. And it's just a very short commercial. We have our annual meeting coming up in July. Hopefully you can accompany us. Dr. Barisata will be joining us. It will be a pleasure to have you. Thank you so much.